So I guess we'll start. Today we are studying. We are talking about otitis. Otitis, it is very accumulated diseases for child and for adult because everybody one time of year ill of otitis. Sorry. Otitis is the external ear infection. External ear infection, external otitis is swimmer's ear, symptoms, pruritus, otalgia, wearing form, sense of foulness, tooth throbbing pain, hearing loss. Things, edema and erythemia of canal skin, tenderness of tragus, full smearing, secretions, possible periarticular cellulitis. Treatment: clean topical otic neosporin polymyxin B or consultin. For gram-negative bacilli, most commonly Pseudomonas aeruginosa for 10 days. Impregnated weak for soft edema, adequate analgesics, preventive measure for recurrent otitis externa, ethyl alcohol drops, 70% all acetic acid solutions, 2% after swimming or bathing, avoid self-instrumation. Necrosing external otitis, malignant external otitis, symptoms and things, progressive pain and drainage from the ear external auricular canal. Granulation tissue often present, Pseudomonas aeruginosa invasion of soft tissue, cartilage and bone. occasional facial nerve palsy. Treatment: radical surgical debridement with combination semi-synthetic penicillin and aminoglycosid for 4 to 6 weeks. Significant mortality in diabetes who acquire disease. Perichondritis symptoms: pain and warmth of the pinna following trauma or infection. Things: erythema, induration, and possible fluctuance of part or all of the auricle. Treatment: most common organisms: Pseudomonas aeruginosa, betadine of boric acid with to dry dressings to open wound. If perichondritis progresses to chondritis with abscess, then incision, drainage, and debridement of non-viable cartilage is necessary. Obtain cultures. Automycosis. Symptoms: itching or middle otolgia. Secondary bacterial infection might produce intense pain. Things: Aspergillus nigrans produced a grayish membrane with HIF visible under microscope. Erythema of interlink epithelium. Treatment: clean external auditory canal, topical cressyl acetate of 1% gentian violet and or boric or acetic acid, and alcohol drops. Bullous meningitis. Symptom: otolgia. Things: hemorrhagic bleeds of TM and adjacent canal. Treatment: incision of bleeds or if serve pain. Prophylaxis: oral antibiotics to prevent otitis media. Anesthetics: otic drop. Zoster oticus. Ramsay-Hunt syndrome. То есть синдром Рамсея. Symptoms: otolgia, malaise, headache, possible dizziness. Things: vesicular eruption of distal canal and concha, associational 7cn paralysis. 7cn это 7th cranial nerve, associational 7th cranial nerve paralysis. Treatment: analgesics, middle canal forced decompression of facial nerve if progressive degeneration. Decompressia 7th canal nerve. middle year. Serious otitis media. Otitis media with effusion. Итак, solve. Otitis media, it is accumulation of non-purulent middle ear fluid due primarily to Eustachian tube dysfunction and secondarily to metaplasia of mucosa. Etiologies of acute otitis middle with effusion. Number 1. Nasopharyngeal obstruction. It is adenoid hypertrophy, neoplasia, iatrogenic. Intratubular obstruction, allergy, sinusitis, URI. Middle ear obstruction, chronic otitis media, cholesteatoma tumor, failure of physiological opening, cleft palate, submucous cleft, some neurological disorders. Other contributing factors: metaplasia due to recurrent or chronic infection, hypothyroidism, diabetes mellitus, immune deficiency syndromes, connective tissue disorders. Symptoms: middle otalgia, stuffiness, autophonia, hearing loss, things retracted, discolored TM, diminishing TM mobility. TM это tympany membrane. TM it is tympany membrane. So things retracted, discolored tympany membrane, diminished tympany membrane mobility. Medical treatment: acute otitis media. Treat nasal congestion or drainage. Treat concurrent infection, adenoids, middle ear, sinusitis, allergic rhinitis, pharyngitis. Antibiotics for otitis media with effusion. Control allergens. Valsalva maneuvers for insufflation. Polycerization. Sequelae of persistent serious otitis media. It is characterized by conductive hearing loss, 10 to 30 decibels, recurrent suppurative otitis media, impaired auditory processing with impaired socialization and delayed speech and language development in young children, ossicular erosion, tympanosclerosis, cholesteatoma formation. Surgical treatment of serious otitis media. Preserve equalization tubes. Recurrent studies have demonstrated that adenoectomy might provide additional benefit, but there is still some controversy regarding this. When to recommended tabs, SOM for more than 3 months, 3-4 episodes otitis media in 1 year, in an year with chronic or recurrent otitis media, and hearing handicap. Acute suppurative otitis media refers to an acute exudative middle ear disease secondary to bacteria. Clinical stage: hyperemia, exudation, suppuration, and resolution. Otitis media, day care. Greater risk of acute otitis media in children small 3 years. Home care best, large group day care worst. More exposures within the range of flora, increased URI. Otitis media breastfeeding decreases incidence of URI and GI diseases. Inverse relationship between incidence of otitis media and duration of breastfeeding, protective factor in breast milk. Otitis media spoke exposure. Induced change in respiratory tract continuum marks associated with increased acute otitis media and persistent infusion. Increased otorrhea, chronic and recurrent acute otitis media in children with of parental smoking. Otitis media medical conditions: cleft palate, decreases after repair, craniofacial disorders, Treacher Collins, Down syndrome, ciliary dysfunction, immune dysfunction, AIDS, steroids, chemotherapy, immunoglobulin G deficiency, obstruction, NG tubes, NG intubation, adenoids, malignancy. Pathology: edema, capillary environment and PMN infiltration, epithelial ulceration and granulation tissue, fibrous influx of chronic inflammatory cells, increase in columnar and goblet cells, osteitis, edema and polypoid change. Pathology: Eustachian tube abnormalities, impaired open in DS and American Indians, shorter tube, impaired immunity, children have poorer immune response, less cytokines in nasopharynx in children with otitis media, inflammatory mediators, bacterial products induce inflammatory response with interleukin-1, interleukin-6 and tumor necrosis factors, and allergy. Microbiology: acute otitis media. 30-35% it is Streptococcus pneumonia. 20-25% at the Haemophilus influenza. 10 to 15% Moraxella catarrhalis, only 2 to 4% at the Streptococcus group A. Infants with higher incidence of gram-negative bacilli. but acute otitis media may be virology etiology. It is respiratory syncytial viral. 74% of middle year isolates. Rhinovirus, parainfluenza virus, and influenza virus, and last 2 years ago, a coronavirus etiology acute otitis media. Complication, it is осложнение. What may be if we don't treatment acute otitis media? It is acute surgical mastoiditis, facial nerve paralysis, acute labyrinthitis, sigmoid sinus thrombosis, and cranial nerve infection. Complications are divided into 2 parts. One part it is intratemporal, 2 part it is intracranial. Intratemporal it is hearing loss, TM perforation, chronic otitis media, retraction pox, cholesteatoma, mastoiditis, petrositis, labyrinthitis, adhesive otitis media, tympanosclerosis, ossicular discontinuity and fixation, facial paralysis, cholesterol granuloma, necrotizing otitis effusion, and intracranial. Intracranial it is intracranial diseases. It is meningitis, extradural abscess, subdural emphysema, facial encephalitis, brain abscess, lateral sinus thrombose, and otitis hydrocephalus. Pathogens. It is microflora, Haemophilus influenza, Streptococcus, Pneumococcus. Very activated slide. I can what you write. This is slide. I can what you write. This is slide because the slide to show treatment acute otitis media. So we are using antibiotic therapy, and antibiotics first line it is penicillins. Penicillins, clavonate protection penicillins, and semi-synthetic penicillins. Amoxicillin it is semi-synthetic penicillin. We are using 30-40 milligrams kilograms per day in 3 doses every 8 hours. Cefaclor 20-30 milligrams per kilograms per day in 3 doses every 8 hours. Trimethoprim 6 to 20 milligrams kilograms per day, and sulfamethoxazine 60 milligrams kilograms per day in 2 doses for 20 hours. Erythromycin, it is macrolides. We are using 50 milligrams kilograms per day in 4 doses for 6 hours. So, chronic suppurative otitis media. Chronic suppurative otitis media, it is complication, acute otitis media. Chronic otitis media refers to a permanent tympanic membrane perforation with associated middle ear and mastoid disease. Intermittent or continuous otorrhea usually exist. Chronic otitis media characterized by perforation tympanic membrane. It is always perforation tympanic membrane. Always tympanic perforation membrane, and chronic otitis media characterized perforation tympanic membrane, and perforation may be central, marginal, etic. 3 types perforation: central, marginal, and etic. Usually associated with cholesteatoma. Perforations are often accompanied by purulent drainage and otic polyps. Evaluation: poor tone and speech, auditory, and mastoid films. Treatment: clean under microscope, topical otic antibiotics, treatment of predisposing conditions, smoking, allergy, chronic sinusitis, chronic tonsillitis, uncontrolled diabetes mellitus, and other, and surgery treatment. Goals of surgery: tympanomastoidectomy, eradicate infection, restore hearing, close middle ear cleft. Cholesteatoma. Definition: a confined epithelial sac leaf expands by collection of desquamated cells and debris. So, cholesteatoma is it a confined epithelial sac which expands by collection of desquamated cells and debris. Classification: cholesteatoma subdivided: congenital, primary acquired, and secondary acquired. Congenital, very rare. Cholesteatoma results from entitlement of an epithelial cells rest within the temporal bone during embryological differentiation of the temporal bone. No tympanic membrane perforation. Usually presents as pearly with mass behind intact tympanic membrane, also as facial weakness. Primary acquired, perforation of retraction pocket in the pars flaccida. Different theories of pathogenesis. Secondary acquired, marginal pars tensor perforation allows squamous epithelium to migrate inward. And complication. Erosion of ossicles, sensorineural hearing loss, labyrinthitis, facial nerve paralysis, meningitis, brain abscess, sigmoid sinus thrombophlebitis, Petrous epitis, neck abscess, abscess basalt. Autogenic and rhinogenic intracranial complications. Self-life-threatening conditions earthing from the speech of infection, respectively from the cavities of the middle ear, nose or paranasal sinuses in the skull cavity. Intracranial complication, rhinogenic, develop in acute and chronic sinusitis, sphenoiditis, frontitis, ethmoiditis, and maxillary sinusitis, and inflammatory disease of the nose occurring much less often from autogenic. Autogenic, develop in acute purulent otitis media or chronic purulent otitis media. Intracranial auto and rhinogenic complications, extradural abscess, subdural abscess, brain abscess, meningitis, sinus thrombosis. The main ways of spreading infection: contact, gematogenous, lymphogenous, pericyclically, perineural, aqueduct of vestibule. Ways of spreading infection from the paranasal sinuses: subdural abscess, sagittal sinuses, frontal lobe abscess, epidural abscess. Ways of spreading infection from the middle ear: ways of spreading infection from the cavities of the middle ear by contact: brick trough of pus under the neck muscles through the top of the mastoid process, abscess of the cerebrum, perisinus abscess, sinus thrombosis, subperiosteal abscess, extradural abscess, abscess of the temporal lobe. Microbial landscape in intracranial complications: Staphylococcus, colon bacillus, Streptococcus, blue pus bacillus, Proteus. Extradural abscess, accumulation of pus between the bones of the cranial valve and the dura mater. Extradural abscess clinical implications: abundant pus from the ear and pulsation of pus reflecting the pulsation of cerebral vessels. Temperature rise, the general condition can be form satisfactory to serve. The main symptom: headache, odor occurring at night, irritation depends on the localization of the abscess. Ophthalmoscopy, congestive optic disc. When the process is localized in the posterior cranial fossa, nystagmus dizziness. The default of the apex in the pyramid of the temporal bone is accompanied by the involvement of the abductor nerve as a consequence, diplopia and paralytic strabismus. Purulent discharge in the auditory canal and symptom of extradural abscess. Subdural abscess, accumulation of pus between the dura and rhachoid meninges in a limited area. Clinical implications: general brain symptom. It is headache, nausea, not related to food intake, confusion prevail. Meningeal and fossal neurological symptoms: The subdural abscess communicated with the subarachnoid space, so it easily passes into meningitis. Clinical manifestation of meningitis. Inflammation of the meninges when infection spreads to the subarachnoid space. Clinical implications. Systemic. Subgeneral condition. Disturbance of consciousness, operation of psychomotor agitation, pallor, photophobia, hyperesthesia, sore fever, leukocytosis, high erythrocyte sedimentation rate. Brain-wide symptom. Strong headache, nausea and vomiting not associated with food intake. Photophobia. Meningeal symptoms. Rigidity of the neck muscles, carrying scenes, symptoms of Brudzinski, forced position of the patient in bed, change the composition of the liquor. Abscess of the brain. Formation mechanism. The infection speeds through the thrombosed veins of the dura mater further into the veins of the white matter in the brain. The process affects only the white matter but not the cerebral cortex. Stage of abscess development. Local encephalitis. Formation of microabscess in the encephalitis zone with a tendency to merge into a single cavity. An increase in the volume of the abscess with the tendency to break into the lateral cisterns of the brain. Clinical stage of abscess development. Initial corresponds to local encephalitis before encapsulation, accompanied by mild headache, temperature to 37.5, nausea, vomiting, poor health. The latent stage of the light gap creates the illusion of recovery, poor in symptoms. There is a lethargy of the patient, lack of appetite, periodic headache. Otherwise, increase in the volume of the abscess is rupture. Focal symptoms of abscess of different localization. Temporal lobe abscess, aphasia, anamnestic and sensory. Hemianopsia, upper quadrant and epithelium syndrome. Frontal lobe abscess characterized by mental disorders, inadequate behavior, aphoria, anamnestic aphasia. So, brain abscess will be characterized by localization form. There is localization, abscess of brain, symptoms may be very different. Abscess of the temporal lobe of the brain. The slide to show abscess of the frontal lobe of the brain. Computed tomography, sphenoiditis, eta A, sphenoiditis, B, magnetic resonance tomography, abscess of the frontal lobe. Principles of treatment of intracranial complication. Emergency surgery. Systemic antibacterial therapy in high doses. Detoxification, decongestant therapy, symptomatic therapy, analgesics, correction of respiratory disorders. Venous sinus thrombosis. Venous sinus thrombosis is the formation and subsequent infection of a thrombus in the lumen of the sinus developing as a result of a spread of the infection process. The pain of infection in the cerebral venous sinus is hematogenic in the course of the venous outflow. Cavernous sinus thrombosis. It is often a complication of nasal boil, much less common in acute sinusitis. Clinical implications. Progressive headache and facial pain, usually unilateral, in the retroorbital or frontal regions. High temperature. Eye symptoms. Ophthalmoplegia. Exophthalms and swelling of the iris. They often become bilateral. Patients often have anisocoria or mydriasis, swelling of the nipple of the optic nerve and decreased vision. Facial sensitivity may be retracted or absent. Since all CNS lesions are a decrease in the level of consciousness, its confusion and convulsions. Cavernous sinus thrombosed furuncle of the nose. The infection is spread by retrograde thrombophlebitis. Through the cavernous sinus pass speeds into the eye and develops unilateral blindness, and if the infection gets into the internal cavernous sinus, then blindness can occur in both eyes. Also, due to the penetration of bacteria into the cavernous sinus, might develop meningitis. This condition is especially dangerous for people with diabetes and in patients with reduced immunity. Treatment: systemic antibacterial therapy. Sigmoid sinus thrombosis. Epidemiology: acute purulent otitis media and mastoiditis. Clinical implications: the general condition of a patient is sort of moderate. Hard-headedness in the occipital parietal region. Pain during palpation of the posterior IgG of the mastoid process, tenderness of the jugular vein on palpation, hectic fever, terrific chills, profuse sweat, inflammatory change in blood parameters. Rarely autogenic sepsis can occur with a constantly high temperature such as continua. Expressed intoxication, multiple organ failure. Sigmoid sinus thrombus, Meniere, and sigmoid sinus thrombus computer tomography. Treatment of sigmoid sinus thrombosis, antibacterial therapy. Emergency standing surgery of a temporal bone. Systemic antibacterial therapy in high doses. Rhinogenic orbital complication. Development with a spread of infection from the paranasal sinuses to the eye socket in the following ways. Contact pathway through defects of bone walls formed as a result of osteomyelitis or congenital bone defects in the cerebral and orbital walls bordering the sinuses, as well as in the channels of the optic nerves. Hematogenic pathway, lymphatogenesis route. Classification of the orbital complications. Reactive edema of the eye socket and eyelid tissue. Diffuse non-purulent inflammation of the retina of the eye socket and eyelids. Periostasis. Subperiosteal abscess. Abscess of eyelids. Fistulas of eyelids and orbital wall. Retrovalvular abscess, phlegmon of the orbit, thrombosis of the vein of the orbital tissue. Reactive eyelid edema. Petrositis of the orbit. There are simple and purulent forms which develop respectively with catarrhal or purulent inflammation of the sinuses. Clinical implication: eyelids with conjunctival vascular injection. High body temperature, general weakness, headache. One of the walls of the orbit and painful infiltration is formed. The localization depends on the localization of the inflammatory process in the paranasal sinuses. Further detachment of the periosteum form of the bone leads to the formation of a subperiosteal abscess. Phlegmon of the orbit. Phlegmon of the orbit is the most short and dangerous of rhinosinusogenic ocular complications. Clinical implications: body temperature 40 graduses, sore headache, possible nausea and vomiting. Local symptoms. It is growing pain in the eye socket, edema and hyperemia of the eyelids, pronounced hemosis. Exophthalmos with limited mobility of the ill bowel. Reduced vision due to impaired blood supply to the retina. Phlegmon of the orbit. Cavernous sinus thrombosis. Appearance of a patient with cavernous sinus thrombosis. Picture Meniere and abscess of the orbit. Picture of Meniere in thrombosis of the cavernous sinuses. Abscess orbit. Treatment of a rhinogenic orbital complication. Conducted jointly otorhinolaryngologist plus ophthalmologist. Urgent surgical treatment, wide opening of the affected paranasal sinuses and simultaneous elimination of purulent focus in the eye socket. With purulent process in the eye socket and the presence of symptoms of vision damage, regardless of the nature of the pathological process in the paranasal sinuses. Non-inflammatory ear diseases. Sensorineural hearing loss. Sensorineural hearing loss, it is complication of chronic otitis media, and one of them complication intratemporal diseases. A form of hearing loss in which one of section of a sound receiving department of the auditory analyzer is affected, starting from the sensory cells of the inner ear and ending with the cortical representation in the temporal lobe of the cerebral cortex. Social and medical significance of the problem of sensorineural hearing loss. Prevalence. 30 million pupils worldwide have significant hearing change. By 2020 years, the population with socially significant hearing loss will increase by 30%. A significant percentage of patients are in the age group of high social and professional activity. The problem of childhood. Congenital hearing loss is one average. The problem of older age group. Early manifestation of presbyacusis in residents of industrialized areas due to chronic noise injury. Audiotal screening in the hospital in 1 to 3 months examination of the hearing center unified database. Maternity hospital diagnosis center, deep center in the absence of screening. The diagnosis is made only by the age of the child does not speak because they does not hear. The child is made only by the age of the child does not speak because he does not hear. The main etiological factors of sensorineural hearing loss: vascular, ischemia and metabolic disorders, atherosclerosis. Infection, viral infection, SARS, coronavirus, flu, herpes, malaise, rubella. Acoustic trauma, barotrauma, traumatic by injury. Membrane rupture, cytotoxic drugs. Immunological, stress response, activation of cellular stress factors, kappa factors B, idiopathic acute SHL. Ototoxicity, drug, aminoglycosid antibiotics, diuretics, non-steroidal anti-inflammatory drugs, anti-cancer drugs, platinum derivatives, ACE inhibitors, enalapril, monopril, anesthetics, antidepressants, aminotrypsyline, non-tryptyline, antimalarial drugs, chloroquine, calcium canal blocked, nifedipine, nicardipine. Industrial factors, heavy metals, solvents, odors. Household intoxication, drug addiction, smoking, alcoholism. Classification of sensorineural hearing loss: congenital, acquired, for the duration of the course, sudden, acute, subacute, chronic. At the time of the occurrence, prelingual, postlingual. According to the degree of hearing loss, there are 4 degrees of hearing loss: speech frequency zones and deafness. 1 degree, light speech frequency zone, 26 to 40 decibels. 2. It is moderate speech frequency zone, 41-60 decibels. 2. Moderate research, 61 to 80 decibels. And grade 4 at research, more than 80 decibels, difference more than 91 decibels. Clinical manifestation of sensorineural hearing loss: hearing loss unilateral or bilateral, tinnitus, violation of intelligibility, possible vestibular symptoms. Lateralization voice, to jest Weber test and Rinne test. Diagnosis of sensorineural hearing loss. Study of auditory function. Otoneurological examination. Study of hemodynamic parameters of brachiocephalous vessels. Indicators of blood clotting system. Radiodiagnostics. Normal audiogram. Violation sound perceptions. Mixed hearing loss. Speech audiometry. X-ray of the temporal bones by sterons. Acoustic neurinoma. Treatment of the hearing loss. Drug therapy. Drugs that improve cerebral blood circulation and metabolism, improve the rheological properties of blood. Piracetam, vinpocetine, pentoxifenolin. Drugs that affect IBD, beta-glucan, corticosteroids, dexamethasone. Vegetotropic therapy, tofizopam, vitamin neurotropic agents, vitamin group B. Dehydration therapy, diacarb. Non-drug treatment measure, reflexotherapy, hydrotherapy, manual therapy, hearing aid, cochlear implantation. Cochlear implantation. A cochlear implant is a medical device that allows partial or complete restoration of hearing in some patients with source of a surgery. Tinnitus. Objective, audible to an outside observer and can be registered using auscultation and other instrumental methods of examination of a patient. 5%. Reasons. Pathology of temporomandibular joints. Myoclonus of the middle ear muscles, soft palate. Dehiscence of the auditory tube. Classification of the tinnitus. Subjective and reasons. Metabolic. Disease of the external middle inner ear, sulfur plaque. Exostosis of the external auditory canal, external otitis, otitis media, otosclerosis, neurosensal hearing loss, acoustic and barotrauma, Meniere's disease, Hunt syndrome. Perception of silence, a manifestation of endogenous somatic sounds, usually masked by environmental sounds in a healthy person who is in a soundproof room. Meniere's disease. It's characterized by variability of hydrotenses and clinical manifestation of peripheral cochlear-vestibular disorders, attacks of dizziness accompanied by nausea, vomiting. Balance disorder progressive, unilateral hearing loss, noise in the affected ear. Meniere's disease clinical classification in shape. Typical a triad of sins described by Meniere: noise in the ear and hearing loss, balance disorder, vegetative disorder atypical, manifestation of individual sins of the trait cochlear vestibular. Adrift, attack, acute period, remission, and status Meniere's. Etiology Meniere's disease. Proximate cause endolymphatic hydros predominance of the tone of the parasystematic part of the autonomic nervous system, which occurs as a result of the vegetative vascular dystonia predisposing factors. Poor circulation in the system of vascularization of the labyrinth. Metabolic disorders, in particular water salts. Dysfunction of endocrine symptoms. The mechanism of development of hydrops of the labyrinth. Hyperproduction of endolymph. Reduction of endolymph resorption. Violation of membrane permeability. Theory of Meniere's disease development: anatomical, genetic, immunological, vascular, allergic, and metabolic. Diagnosis of Meniere's diseases: computer stabilometry, video oculography, audiometry, vestibular myogenic evoked potentials, electrocochleography, transtipaniral electrocochleography, dehydration test, duplex scanning of brachiocephalous vessels, variation heart rate monitoring, magnetic resonance imaging of the brain and cervical spine. Treatments of Meniere's disease: conservative treatments, beta-histine hydrochloride, dehydration therapy, vitamin therapy, sedative therapy, psychotherapy, reflexotherapy, surgical subdivided into cutting the drum string drainage and the lymphatic circulum, incision of the cochlear vestibular nerve, laser destruction of the labyrinth, intratympanial injection of a solution of gentamicin. The relief of an attack: it is bed rest, exclusion of brief white, loud sounds, 1 milliliters of 0.1% solution of atropine sulfate, or beta-histine 48 mg. Methods of rehabilitation measures in patients with Meniere's disease. Exercise on stabilographic complex. Physical therapy aimed at improving statokinetic stability. Correction of patient anxiety, uncertainty and fear. Natural factors. Climate therapy, mud therapy. Thank you for your attention.